That's ugly.
This is supposed to be 10.
Actually, this is the widescreen.
Yeah.
I'll just leave it like this for now. Okay.
All right, you ready?
Yeah.
You can turn it on now. I see a light.
That's good.
Are you ready for this one?
Right.
Oh yeah. You could. You have a PowerPoint or something to present? Oh, okay.
Okay. All right.
Hook it up onto here.
Yes. I think it's over there.
I have a lot of stuff on this USB, so is it coming up?
Yep.
Not recognized, it says. Let me take it out and put it back in. That's a USB. Does this have internet the other one? Just in case.
It does. I think it should be coming up soon.
You have to install the software for the USB? That's crazy.
You know, the other thing we could do is if it connects to the internet, is just use the slides from the courses or they're about different.
No, they're exactly the same. I'm going to try the other one. The light is on, so it definitely recognizes it. At least it's there. It's like, not worked up before you have to give a lecture. Certainly worked up after this situation.
Do you mind giving it to me PDF?
I don't care. As long as I can use the mouse on it.
Yeah.
Stuff on.
Actually, and you emailed it to Betty
Oh yeah.
as a PowerPoint?
Yeah.
Because maybe if this is a PDF, we can just use your email. That might be because this is a PDF, right?
Okay.
So why don't we use her PowerPoint instead? Or you can get there through that.
Just go to Columbia.edu.
Yeah, it might be. Oh, sorry.
Good.
Here we could just.
I've never used it online.
Oh yeah, no, don't worry. We're old. We use it all the time. Oh, I think you just have to put in PUF1, right? Or you have to put in MC? Guess we'll see.
I mean, this is the way I sign into my email.
Oh, is that right?
Yeah.
Oh, wow. You're right.
What's her name? Betty?
Yeah, but it might be in the sent instead of the...
Thank you. This is ridiculous.
Can you open that here, or is that...
Oh my god.
This one?
pituitary
No,
disease.
this one. This one.
It's not opening. All right, I guess we just need to go to the coursework, so I don't know what else to do.
Can you pull that into the computer?
Yes.
Okay. There we go.
Ah. Craziness. It looks funny, but
Sorry about that.
you know, it's Columbia. All right. Now we got to get it up onto the thing. It might be that the power to the projector is not on. We don't know. Something should show up there, right?
Yeah, something did show when it was starting up, but it never projected the screen.
Yeah, the nothing's coming up on the screen, so it might not be. It might be the power's not up on that. I can see the slides here. If you want me to do it without showing the projector, I can start. You want me to start? Okay. Okay, I'll try. It's a little bit tough, but anyway. Okay. So I'm Pamela Freda. I'm in the endocrine division, and I'm going to talk to you today about pituitary disease. Sorry so much for all the confusion, but I think the slides, we're showing it from coursework, so should be okay. Okay, so I'm on the first slide. I'll try to say next slide or something like that. So if I don't, just call out, whatever. We're not being formal today. So, okay, so I'm on the first slide. These are my disclosures. Next slide. Okay. Next slide. These are the learning objectives. To learn the causes of pituitary disease. Maybe I won't read this since we're in a rush. You can read it. Next slide. Okay. Great. Okay, so I know Dr. Wardlaw spoke to you yesterday about just general pituitary physiology and the hypothalamic pituitary axis, but just to remind you, I don't know, you're probably not going to be able to see my pointer, right, because it's not showing up on the slide. So sorry about that. But if you look in the middle of this slide, you can see the pituitary gland. Up above it is the optic chiasm, and sort of behind it, you can see the hypothalamic pituitary stalk. This is what we call a coronal view, looking straight on at the pituitary. And you can see to the sides of where the pituitary sits in this bony cella is the carotid artery in the cavernous sinus, and all the cranial nerves. So it's important to understand this anatomy so we can think about all the things that happen when you have pituitary disease. And this is just another view, because we're going to look at a couple MRIs related to this. The projector won't come on.
Oh, the projector's on.
Can I keep talking while you're
Sure.
working?
Go right
All
ahead.
right. This is what we call a sagittal view, right down the middle, looking at the pituitary in red here, the anterior and posterior pituitary. And you can see, again, the anatomy here related to the sphenoid sinus in front of the pituitary. Okay, next slide, which is a schema of the hypothalamic pituitary axes. And Dr. Wardlaw, again, went over this with you, but just to remind you that pituitary is controlled by the hypothalamus above through releasing and inhibiting factors. Anterior pituitary hormones, which she told you about, are shown to the left of that slide, and the posterior pituitary hormones below that. And you know that the pituitary hormones come out the anterior pituitary or posterior pituitary, but predominantly we're talking about the anterior pituitary hormones that go out into the circulation to the target gland, whatever it is, the thyroid, the adrenal. Those target gland hormones feed back at the pituitary and the hypothalamic axis. So this is just a reminder of what you heard about yesterday. Next slide. So what are the causes of pituitary disease? And these are the things we're going to talk about mostly in this lecture. The main category are mass lesions involving the pituitary or of the hypothalamic pituitary stalk, because if they're in the stalk, they're going to affect pituitary function by interfering with pituitary function because of the signals sent through the stalk, or lesions of the hypothalamus by the same sort of mechanism, feeding down and inhibiting or interfering with pituitary hormone function and secretion. There's some genetic abnormalities that cause pituitary disease, some inflammatory or infiltrative processes we'll talk about, and then various other causes. So what are some of these? Now we're going to go through sort of specifically a number of the main causes of pituitary disease. The biggest cause are tumors and other mass lesions, and the most common of these are pituitary tumors. They can either be hormone secreting or non-hormone secreting, and I'm going to spend most of the lecture talking about those. And just to make it clear that a pituitary tumor is monoclonal in origin, starts in, we believe, one particular pituitary cell. So the cell of origin is really what characteristics the tumor takes on in terms of hormone or non-hormone secreting. And that's distinct from pituitary hyperplasia, which we're not going to talk that much about, but just so you know, hyperplasia obviously is enlargement of all the cells in the pituitary, and there are some causes of that that are distinct. You can have in pregnancy lactotroph hyperplasia, which are the prolactin-secreting cells. You can have thyrotrope hyperplasia in primary hypothyroidism. You can have, very rarely, somatotroph, which are the growth hormone-secreting cells, hyperplasia. We'll talk a little bit more about the causes of growth hormone excess tomorrow. But these hyperplasias should really be able to be distinguished based on the clinical setting. So now to just go into some of these mass lesions in more detail. And I'm going to talk to you first about, next slide, this is causes of pituitary disease, tumors, and other mass lesions. The non-pituitary lesions that are not pituitary tumors we're going to talk about first, since we'll spend a little less time on them. But the categories of those non-pituitary lesions, you have craniopharyngiomas of the benign tumors, and I'll tell you more about that. Meningiomas, tumors of the meninges that line the brain, also can be in the pituitary area and sometimes look very much like a pituitary tumor. There are various cysts which are in the pituitary area sometimes, Rathke's cleft cyst, which is really a developmental cyst of Rathke's pouch that never completely comes together, and sometimes those fill with fluid and become a cyst. There are also various malignant tumors that can go to the pituitary, either in the clivus bone, which is the bone right behind where the pituitary sits, or various metastatic tumors can get into the pituitary. They tend to have a propensity for the posterior pituitary, and we'll talk about what can be involved then. And sometimes lymphoma can get into the pituitary area. There are also a number of granulomatous, infectious, and inflammatory diseases that can affect the pituitary. Sarcoidosis can actually go into the pituitary, or the meninges, or the hypothalamus. Tuberculosis, there can be an abscess in the area, usually tracks from below the sphenoid sinus. And also lymphocytic hypophysitis, which is a inflammatory infiltrate in the pituitary. Typically and characteristically, it's been occurring late in pregnancy or early postpartum period in women, but other people can be affected. Next slide. Regarding, again, causes of pituitary disease, this time the hypothalamic diseases, there can also be mass lesions in the hypothalamus, craniopharyngiomas, germ cell tumors, and also any kind of radiation that a patient might have received for a central nervous system tumor. Also nasopharyngeal cancers can end up affecting pituitary function. And again, these infiltrative lesions that can be in the pituitary can also be in the hypothalamus or even the stalk, sarcoid histiocytosis or tuberculosis. Next slide. So I just want to say a little more about craniopharyngiomas because they're quite common. Of the non-pituitary lesions, they're probably one of the most common we see, aside from just Rathke's cleft cysts also. But they are benign tumors. They arise from remnants of this Rathke's pouch that occurs anywhere along from the hypothalamus to the stalk to the pituitary. There tend to be like solid and mixed tumors, and they occur in two bimodal distribution. About half occur in children and adolescents and about half in adults. And they are a little unusual compared to pituitary tumors. They tend to cause more pituitary insufficiency and also can present with vision loss. They are treated with surgery depending on where they're located, whether it's transsphenoidal, I'll tell you a little bit more about that, or a craniotomy, and then radiation. Next slide. I'm talking fast, trying to make up time. I'll try to slow down a little bit. Other causes, next slide, the miscellaneous other causes. You can have vascular lesions that are aneurysms or other vascular lesions, mostly aneurysms around the pituitary area in the carotid that can actually cause hypopituitarism. And pre-MRI, some of them really looked like pituitary tumors. You can have something called pituitary apoplexy, which is basically like hemorrhage or infarction into the pituitary. Usually that presents with a sudden headache from sudden expansion and bleeding into the pituitary. We don't know all the causes of it, but patients present sometimes with cranial nerve palsies and hypopituitarism, and if it's severe, it's kind of an emergency to treat the hypopituitarism and do surgery to decompress the blood. There's also something called Sheehan syndrome, which is infarction of the pituitary that classically occurs peripartum or postpartum. Head trauma can also cause stalk lesions and hypopituitarism. There are genetics diseases I'll tell you about, and something called empty cella syndrome, which is a little bit of a misnomer. It's not actually that there's nothing in the cella. What it is that the CSF, the cerebrospinal fluid, is actually pushing down into the pituitary area. Sometimes the cella is enlarged and it just looks like there's more CSF and less pituitary. It can be somebody who it occurs classically in women who've had many pregnancies and also sometimes patients who've had a pituitary tumor that's been treated. And usually it's not clinically significant, but sometimes it can cause hypopituitarism. So next slide is the genetic disorders. It's a table. You don't need to know all these genetic disorders of pituitary disease. I just list them here so you'll hear more about these from the pediatric side. But I'll just tell you about two in the combined pituitary hormone deficiency category towards the bottom third of that slide. You'll see those listed because those would be what we'd more often diagnose in adults. So next slide is genetic causes of pituitary disease. Just want to tell you about two of these, as I mentioned. One are the PROP1 mutations, which are the most common cause of familial or congenital, sporadic congenital pituitary hormone deficiencies. And what they are mutations in a gene encoding a transcription factor that's necessary for all these different cell types, the somatotroph, lactotroph, thyrotroph, and gonadotroph cells. So you end up with deficiency of multiple hormones. And they tend to evolve over time, and in particular the ACTH deficiency comes late. It's autosomal recessive. The other mutation to know about, in particular for adults, are these PRU1F1 mutations. Also, they can be recessive or dominant. And these mutations are in a transcription factor that's necessary for differentiation of just the somatotroph, lactotroph, and thyrotroph cells. So you'll end up with growth hormone, TSH, and prolactin deficiency. The next slide. So, to talk about just a second the clinical presentations of a pituitary mass, and I think Dr. Wardlaw talked to you, showed you some visual field deficits yesterday, but just to review some of that, they can kind of be broken into major categories. One are kind of structural problems that you can have related to the structure of the pituitary disease or the mass. The other may be hormones. So in terms of the visual and neurologic abnormalities, a main problem is headache. Many patients with pituitary tumors and other pituitary disease complain of headache, but a lot of people complain of headache, so it's not a very specific sign of a pituitary disease, but it's common. Then you can also have visual field deficits, which are specific for pituitary often, something in the pituitary, not necessarily a tumor, but the upward extension of the tumor onto the chiasm causes the classic bitemporal hemianopsia. That's really a classic visual field pattern of loss for pituitary lesions. And that can progress to full visual field loss and even blindness, and if the tumor's been there long enough and hasn't been treated. And the other thing that lesions of the pituitary can do, which if you recall the picture I showed you showing so many cranial nerves are right on the sides of the pituitary, that a pituitary lesion that suddenly expands, such as the apoplexy I told you about, or some inflammatory and infiltrative lesions can present with a cranial nerve deficit. The most common are the 3, 4, and 6. And I will make the point that pituitary tumors, being benign and slow growing, we'll talk about that a little more, rarely present with a cranial nerve deficit. It's interesting. So a patient coming in with a 6th nerve palsy, for example, and a sellar mass is more likely to have maybe an apoplexy or something infiltrative or inflammatory than a pituitary adenoma. So next slide, what are some of the other clinical presentations of pituitary masses and disease? The first is signs and symptoms of hypopituitarism. So we're going to go through all of those, and they can also have signs and symptoms of a hypersecreting syndrome, because if the tumor is hormone secreting, and we'll talk about those. And the other clinical presentation, which we really see a lot of, are incidentally noted pituitary lesions on a scan done for another reason. Like everybody who walks into the ER gets a CAT scan or MRI. And actually, probably 1 in 5 people actually have a little pituitary adenoma. And most of them are tiny and of really no consequence, but we're doing a big longitudinal study of incidentally discovered pituitary tumors here. And finding these leads to a lot of workup and evaluation and follow-up. So even though they're usually clinically not of significance, they are important and being found more and more commonly on imaging studies nowadays. And just to go into that imaging, just so you know, next slide, the pituitary gland imaging, MRI is really the gold standard for imaging the pituitary. You can see it on CAT scan, but it's not as good. You can see, and I'll show you a couple slides really beautifully with modern imaging, a lot of the structures around the pituitary, even sometimes the cranial nerves, and we give these scans with and without the gadolinium contrast, and I'll show you why. So this is, next slide is a normal pituitary gland. You can see, sorry about, we don't have the pointer, but the optic chiasm sort of in the middle, the hypothalamic stalk coming down, and then it's connecting below to the normal pituitary. And you can see it has shape in the middle. And on the right side, the sagittal view, you can see right in the middle the pituitary gland, a little bit of a bright spot in the back of the pituitary. That's a normal bright spot where the vasopressin is stored, and then the hypothalamic pituitary stalk connecting it above and the normal pituitary. Hopefully they'll get us connected. I can come back to the scans because you really need the pointer. And then the next slide, again, what a microadenoma would look like. So micro is a small pituitary tumor, less than 10 millimeters, or less than a centimeter. And where those red arrows are, fortunately there's some arrows, you can see that there is a hypodense area in the pituitary. So normally that gadolinium is important because the normal pituitary picks up gadolinium. And when you have an adenoma, it doesn't always pick up the gadolinium, or they're out of sort of phase. So you can see a hypodense area, that's a microadenoma. And so what does a macroadenoma look like? Here's a real patient of ours. On the left is a big macroadenoma. I think you can pick it out, the relatively unenhancing lesion, and the whiter area around the edge of that superiorly and posteriorly is probably the normal pituitary. And then on the right-hand side is the coronal image. You can see the black circles on either side of the carotids and the unenhancing macroadenoma with the pituitary. In this image, it's sort of on the left, and you can make out above the pituitary the optic chiasm is like draped right over where the tumor is. So what are some of these signs of hypopituitarism? And in this lecture, I'm kind of give you an overview of a few different things, because as you go through each section later in the course, you're going to go into more detail. But just to get you set, as you go through each system, you're going to be hearing more about these. So this next slide is on hypopituitarism, and the one we worry about the most is secondary adrenal insufficiency. And basically that is when your ACTH is deficient from the pituitary, your adrenal doesn't produce enough cortisol, and the symptoms of that can be anywhere from a little lethargy and weakness, anorexia, nausea, to frank hypotension. And it's really a medical emergency, treating adrenal insufficiency if it's severe. And you'll hear more about that. We replace with the target organ hormone, for the most part, in a lot of hypopituitarism cases. For adrenal, we replace with glucocorticoids, and we have oral glucocorticoids, hydrocortisone, or other synthetic steroids we would replace a patient with. What about the next slide, secondary hypothyroidism? Secondary hypothyroidism is abnormal TSH secretion, which leads to thyroid hormone deficiency. The symptoms of that: fatigue, dry skin, constipation, bradycardia, cold intolerance, and something called delayed relaxation of the reflexes, which you'll learn about, and some puffiness overall and in the hands and feet. And we replace that with oral thyroid hormone. The other aspect of hypopituitarism is secondary hypogonadism. In women, a whole spectrum. This is the women on the left, a whole spectrum of irregular menses to infertility to bone loss due to estrogen deficiency. In men, a whole spectrum of symptoms: decreased libido, gynecomastia, infertility, again, bone. In men, we treat with testosterone. It can be by injection or a patch or a gel. In women, depending on the age, that'll decide how we're going to treat them. If they're postmenopausal, maybe estrogen replacement therapy. If they're premenopausal, cyclic estrogen or progesterone. Or if they're desiring pregnancy, then we're going to treat them with, say, gonadotropins or maybe HCG, which you can use for men or women to restore fertility. Growth hormone deficiency, the next slide, is generally a mild syndrome in adults, but some people are very bothered by it. It is not life-threatening or medically necessary to treat, but we do treat with growth hormone. The symptoms of growth hormone deficiency in adults are very different than children. You'll hear all about how important this diagnosis is to make in children. In adults, it's generally an increase in fat mass, some decrease in lean body mass, some lipid abnormalities, cardiovascular risk markers, and decreased bone density. The treatment, again, is controversial and made on a patient-by-patient basis, and we treat with growth hormone injections. And I'll say a bit more about this tomorrow. The other aspect to hypopituitarism is the posterior pituitary deficiencies, and that really is, for our purposes, vasopressin deficiency. And when you're deficient in vasopressin, it's something called diabetes insipidus, and basically you're unable to concentrate the urine. The clinical manifestations are urination of large volumes of dilute urine. Patients get very thirsty. You can monitor it by following the urine volume, specific gravity, the serum sodium. In difficult cases, you can do a dehydration test. Just not have the patient drink or eat anything for a number of hours and find out if they can concentrate their urine or not. And people with DI will not be able, that's diabetes insipidus, will not be able to concentrate their urine. And we can diagnose it by the serum sodium as well as the intakes and outputs. And fortunately, we have a good treatment for that, which is a synthetic form of vasopressin called DDAVP, which we can give as a nasal spray or as pills or injections. So now on to pituitary tumors. I don't think we're going to finish this in time, but just to tell you about the different kinds of pituitary tumors. So they are benign, as I said, monoclonal, and they can derive from any of the different cell types. The lactotroph, the prolactin secreting, are probably the most common. The next type are what we call clinically non-functioning, and I'll say some more about that. But I don't have to read this list here, just you can see what we call the different types of tumors that originate in the different cell types. They're more common in adults. Overall, they're equally common in men and women, although some types of tumors, like ACTH-secreting tumors that occur called Cushing syndrome, I'll tell you about that, are more common in women. And most often, pituitary tumors are sporadic. Okay, but they do occur rarely in some genetic syndromes. There's MEN1, multiple endocrine neoplasia 1, where you can have parathyroid tumors, pituitary, and pancreatic endocrine tumors. That's autosomal dominant. And there's actually also something not listing here, which is called FIPA, familial isolated pituitary adenomas, that's relatively recently described, where patients just have pituitary adenomas in the family. And as I said, they're not all that uncommon, pituitary tumors. I just want to say, because we're going to spend, as you go through the endocrine course, a lot of time on different hormone-secreting tumors. I'll spend a little more time on the non-functioning tumors here, because they are very common. Most are derived from the gonadotroph cells, actually, but rarely do they produce a clinical syndrome. So we call them clinically non-functioning pituitary tumors. So they're not functioning or secreting, but they often are, making something in the cell, so that if you do immunohistochemistry on these tumors, you'll see LH or FSH or alpha subunit on the tumor, and so they're of gonadotroph lineage. They're often, because they don't have a clinical syndrome, they don't get picked up like a Cushing's patient or an acromegaly patient as early, so they're often very large when they present. Not always, but if they're presenting for symptoms, they're usually large. Hypopituitarism, vision abnormalities, and they really have to be treated surgically with transsphenoidal surgery through the sphenoid sinus, removing the tumor. If the surgery is not successful, then they get repeat surgery, sometimes irradiation. Very rarely do they produce a clinical syndrome, which I listed on the bottom of this slide. Okay, next slide. So I'm just going to briefly whiz through a couple of the hormone-secreting tumors. I'm going to tell you a lot more tomorrow, hopefully when the slides are working, about acromegaly and growth hormone-secreting tumors, so I won't tell you anything about that today. The other type of hormone-secreting tumor, which you'll hear about in the Cushing section, are ACTH-secreting tumors, lead to high ACTH and cortisol, cause Cushing syndrome. And you'll hear a lot about this in the other section, so maybe I'll skip over this Cushing's disease manifestation slide. The TSH-secreting tumor, you're going to have a thyroid section. I don't think they cover the TSH-secreting tumors. They're pretty rare, very rare actually, and they're very interesting because they cause symptoms of hyperthyroidism, but with a high normal TSH. You'll learn about primary hyperthyroidism of the thyroid. And the important distinction there is when it's coming from the thyroid, the TSH is suppressed. But in TSH-dependent hyperthyroidism from a TSH-secreting tumor, the TSH is not suppressed. It'll be normal and sometimes a little elevated. But they'll be hyperthyroid because the TSH is driving the thyroid, and they have all the classic symptoms of hyperthyroidism, even with a goiter and a large gland. And what we see is a high free thyroxine level, a normal or elevated TSH, and we don't have a lot of treatments for these, but usually we do surgery. Some patients can also be treated with the somatostatin analog, which I'll tell you about tomorrow, is used primarily for acromegaly. So next slide, just another MRI, just to show you some of the things that can happen with a not so easily treated surgically pituitary case. You can see the big bulk of tumor in the middle, and then this big bulk of tumor off to the side on the left in the preoperative MRI. That's in the cavernous sinus because it's lateral to the carotids, and that's very difficult, probably not accessible safely surgically. But when surgery was done, you can see the whitish on the right is what's left of scar tissue and everything, and then the residual tumor. And somebody like this, if it's a non-functioning tumor, we might follow it, do gamma knife radiation, but that's mostly what we can offer for some tumors like this. So now hyperprolactinemia, which is very important, and we're on the next slide on hyperprolactinemia. Basically, that's defined as an excess of serum prolactin, and it can be a prolactin in men, it's generally over 20, in women over 25, but it kind of depends on the hormone, the assay, you know, the way that you measure the hormone in the laboratory. And it's important because it's really the most common endocrine disorder we see of this hypothalamic pituitary axis. Some older studies show it be somewhat less than 1%. And there are a lot of etiologies, and the reason why we spend some time on it is it's common, and also it's very often not a pituitary tumor. So it's important to think about all the other possible causes of this. And next slide, what are the pathological causes of hyperprolactinemia? I think Dr. Wardlaw told you about physiologic prolactin yesterday, and the importance it has in lactation and when it goes up in pregnancy. But when it's not in those physiologic settings, what are the pathologic causes? And there are kind of two broad categories. One on the left here are the pituitary hypothalamic disorders. So you can have a prolactinoma, a prolactin-producing cell from the lactotroph origin. Acromegaly, growth hormone-secreting tumors, I'll tell you about, can also raise prolactin. Any other lesion within the pituitary area that interferes with the stalk, and I know she told you that prolactin is the one hormone that's kept low in your blood, right? And it's kept low by dopamine and these signals coming down through the stalk. Anything that is pushing on that hypothalamic pituitary stalk, interfering with the normal inhibitory signals to prolactin, can raise prolactin. And in some cases, we call that a stalky prolactin. It's mildly elevated. So any cellular mass, really, any infiltrative process, and as well, the hypothalamic and pituitary stalk lesions can raise prolactin. And then other causes, not due to a mass or primary hypothyroidism, can go up in seizures. We see modest elevations of prolactin in polycystic ovary disease. Other kinds of neurogenic causes, prolactin will go up in renal insufficiency due to decreased clearance. And the big thing is really medications. So on the next slide, I have a lot of the medications, and probably the list is even longer. Very often we get called to see patients on the psych floor in the hospital who have high prolactin, and then it's a challenge to sort out what it is, but there are many medications, a group of antihypertensives, some GI medications because of their dopamine antagonistic effect. You have antipsychotics, antidepressants, and various other causes. So it's important to keep these different categories in mind. And what are the manifestations of hyperprolactinemia? Well, the general principle here is that high prolactin, what it does is it goes back, feeds back, and suppresses the gonadotropins. So when you suppress the gonadotropins, the LH and FSH, you're going to feed down through the axis and lead to gonadal dysfunction. Okay, so this occurs both in men and women, but the degree of gonadal dysfunction is variable. It depends on the person, how high the prolactin is, but in general, in women, on this slide, any variability of amenorrhea to oligomenorrhea, all the way infertility, galactorrhea, milk coming from the breast, any other symptoms of estrogen deficiency, and again, bone loss from the estrogen deficiency. And in men on the right, again, the whole spectrum of symptoms of decreased libido, infertility, etc. And the next slide, how do we treat hyperprolactinemia? Well, the main, fortunately, I showed you all these big tumors and doing surgery, transphenoidal surgery. Fortunately for pituitary tumors that are prolactin producing, we have medical treatment. And they are the one group of tumor that we really can successfully treat with medication in nearly all patients. So that's great news. And the class of medications we use are called dopamine agonists. And they're really primary medical treatment for almost all patients. And if they're not successful, which is a small group of patients, we can treat them with surgery or radiation. There are a lot of nuances and caveats to the treatment, but some people with high prolactin and a small pituitary tumor don't need to be treated because prolactin, goes up in pregnancy. It's not an unsafe hormone in and of itself. It doesn't do anything except if it's not affecting the gonadal axis. So some people don't need treatment with a small tumor, and that might be a postmenopausal woman who has a tiny microadenoma, and you don't need to treat it necessarily. You could, but you don't have to because she may not be symptomatic and it's tiny. Or a man with totally normal gonadal function and a tiny microadenoma, you may not need to treat. So there are different groups of patients. Obviously, somebody with the big tumor, like I showed you that big tumor, say the one that was in the cavernous sinus, you're going to treat that kind of tumor with medication, obviously. Okay, so next treatment. And next slide on treatment goals for hyperprolactinemia. Why might you treat somebody? There's two main reasons. One is to restore gonadal function, obviously very important, improve sexual function and fertility. And the second, if the galactorrhea, if the milk is bothersome, very effective treatment for that. It will lower the prolactin. Then the other main group of reasons is the tumor mass. Even if the prolactin's not necessarily bothering the patient, they don't care about fertility, if it's a big prolactinoma, you still need to treat them. Reverse the signs of mass effect and to preserve and restore the pituitary function. And how do we treat these tumors? We have two medications available in the U.S. now. We have bromocriptine, which is their first medication really developed. It starts once a day or multiple times a day, depending how much you need to give. And then cabergoline, which is a longer-acting dopamine agonist, and it's given once or twice a week. And they're both effective. Cabergoline has a somewhat better side effect profile, and we generally start with that, except that for women who are looking to get pregnant, some of us would use bromocriptine because it just has a little bit longer track record. They're both safe for pregnancy, and you're using it a lot too in young women with hyperprolactinemia. So this is important consideration. Both are safe, but we might go for bromocriptine first. And what does it look like when you treat them? It's really kind of a miracle and a great situation treating these patients with the dopamine agonists, because in nearly all patients, let's say over 90%, the prolactin comes down and the tumor also shrinks. It's really remarkable. So on this MRI, this next slide shows the MRI of the tumor reduction with dopamine agonists. You can see in the top two panels the large macroadenoma, the cellar, what we call in the cella, and extending supracellularly. In this case, this tumor is enhancing with the gadolinium, and you can see the whole enhancing area. And then the bottom two panels are after treating with the dopamine agonist. So this is not too uncommon. So it's really a remarkable thing to be able to treat these dopamine agonist tumors with the medication. And I guess that's it. I don't know how I made up the time, but sorry. I must have been talking a million miles. So sorry to rush you, but I'm happy to take, questions, because I did go through it fast, and I'll be back tomorrow for the second half of the lecture tomorrow. So if you look over this and something wasn't clear or I talked too fast and didn't make any sense, come talk to me tomorrow or send me an email if you have any questions, or come up after this. Fine. Okay. Thanks. Come up if you don't want to call out. Just come up and ask questions.
I'm just curious.
Sure.
Are these tumors, do they tend to be very slow growing?
Yes, they tend to be slow growing. Sorry, I guess I forgot to say that. I was talking too fast. Some are aggressive, but overall, most pituitary tumors are slow growing. Mm-hmm.
It's okay. Just keep going.
Next. Nobody else? Okay. Craziness. He still couldn't get the...
No.
What's going on?
I don't
So
know.
the next one, it's very hard to do the lecture by saying next slide when we're not used to
You
it.
just do it yourself.
Yeah, but they tell, it's
Yeah.
really-
Oh, you just okay. I see.
But what if they don't have their computer? I mean, fortunately, they all pretty much have their computer, but if they don't, what a craziness. It's not good. So we don't know what's wrong?
What?
We don't know what's wrong? Something to do with the rebooting?
I don't know. I'm gonna give it another try. See what's.
I have no idea what I'm doing. I usually embellish more, but I have like... Maybe I skipped a whole bunch of slides, and I don't know. Like the cushions and... Yeah, I skipped over that. Yeah. I'm sorry, but I don't know. It's not your Yes, the common 15s are around the 90 years. This is the first generation. Seniors are not The other one is relatively newer. And so even though there's an opposite, just if you had a choice, you would always go with something that you use more tried and true. So it's obviously if you don't tolerate the 115, you use the other one. It's not
Did you say that the other drug, that one quickly, is
I live with hope. Do you need this just for me or not yet?
Not yet.
Okay.
So treat the other kinds of tumors, and you're going to talk about that. Tomorrow I'm going to talk about protein trees and treatment groups. That's a whole other thing. The reason why we do yeah, right. So different types of tumors have different syndromes. So you have all those different hormones, right? You have TH-secreting tumors, they cause a syndrome. TSH-secreting tumors cause a syndrome. They're all kind of treated differently. So that's the surgery. But the prolactin is the one where you always go to the acid first.
When the tumors are in different places, how do they manifest as different diseases? So I guess I'm picturing.
Yeah, within the pituitary nucleotide. Yeah.
So you just have to look at symptoms and that's it.
Yeah, so we look at it, MRI, they all kind of look the same. And you can't tell just looking at it. You have to look at the blood test, and you have to look at the patient. So that's pituitary. So they all kind of look the same, and you have to do, that's why the endocrine people are very involved in pituitary work, because we have to measure the whole profile of the hormones, and then go from there.
No, it's okay. And then how does hyperprolactin or prolactin feedback on the OSC?
I'm not sure exactly what the molecular mechanism is. Dr. Wardwell might know about that. She didn't say anything about that yesterday. Okay. Oh, okay. Check her lecture that she talked about. She's more like involved with that.
Stole. It's projectors on. You gonna try that? Switch to laptop. Nope. Nope. I saw it there for a second. Okay, well that works. Why is it not going to?
So it's the PC. Something wrong with the PC. Or
No.
wish I could do HDMI.
You think the HDMI cable's bad? You get it?
We have an HDMI cable that runs to the laptop feed. So once we select laptop, the signal should go through
Okay,
instead.
so if we just could borrow someone's laptop?
Actually, I'm going to use the laptop wire to go into the PC too.
No, see, it's plugged into the computer right now.
No, I know. I disconnected the computer and I just tried to stick in the laptop.
No, I stuck in the laptop.
All right.
No, it should be. I'm saying it should be.
Working.
It should be working right now.
All right. Try the VGA one here. Pull that out. Because I know the VGA cable works because I plugged that in.
Yeah, you should be able to see something now.
Let me flip it back.
No, it's still going to be laptop.
No, I'm flipping it between PC and laptop.
It should be.
But if we just use
It's the
what you did-
PC. Yeah,
It's this. Right?
it's this.
the
This
computer.
is giving us problems right now.
It's the computer.
do what you
Yeah,
did?
yeah. If you borrow the laptop, it'll work. It's the PC.
What? You want to try just restarting it? You see what that's going to, if that's going to do anything? Because we never restarted the PC.
No, it was shut off.
What?
It was shut off. The
Yeah.
power to the PC was off, and we turned it on.
Okay, well just restart it again and see what happens.
All right, so we're gonna lose this though.
That was the last speak. Whatever.
So we have a laptop we can plug in.
Okay. You know what?
You
I'm
know-
gonna do that. What kind of laptop did you have exactly?
Yeah, it seems like it's the PC which is giving us the issue here.
should.
It should.
Yeah.
Or we could just open it up and if you send it to your email to them.
Yeah, that's what we need is a laptop.
Yeah,
They're having a student provide one.
yeah. Well, they get.
What kind of connection do you have?
Yeah, that's what Dave brought his iPhone.
I gotta go back downstairs.
Oh, all right.
It's a different connection because if you look here on this side, you got that little square one, and these are iPhones. So I gotta get the adapter. I'll be right back with it.
Okay. So maybe we can just upload the. Do you have the internet on here?
Yes.
So you can just open up Dr. Aronoff's email and she can find her slides there and then it's.
Can we just use this?
You think this will if this will work in the.
Do you think it's on here? I think so. Thank you. Yep.
No, that's not the right one. Normal growth. That one. Let me just make sure that's the right one. May 2015. Yes, that's it.
Just gotta wait for the adapter,
Okay.
and hopefully that'll work.
Now you won't be able to take notes.
That's okay.
All right,
I
thank
can
you.
do it up here.
Thank you very much.
That's all right. Yeah, there's the. Unplug it. Oh no, that's power.
There should be another one. Here.
Yeah, I think we can just close that. And it should work.
Does the HDMI cable work, or does that not?
Hold on. You see that? It's working now.
Oh my goodness.
You want to just pull this?
Your safety and your partner,
Yeah.
please.
Yeah, yeah. Put that back in there and put that back in there. Which Dave?
Okay.
Where is it now? Is it?
It's in 2015 lectures. It's May. Where is it? Normal growth, first year med students, May. Up one. That should be it.
No, that's not the right one.
That's not the right one.
It's this version. Right there.
Okay.
So what happened? You restarted the computer?
Let's
Yeah. See when I restarted it.
Let me make sure that this. Oh.
Right.
Oh.
Yeah, that looks.
That's
like
it.
Okay. Now let's make sure this works. You want to start there, right?
Yes.
Okay. Come on.
Oh my goodness.
There we go.
All right.
All right, let me just do this for you.
How come it didn't work the first time?
Just give me a sec, Dave. Swear these people eat batteries. Okay, that's on, that's on. I'm going to put this here for you. And you're on. Okay. Yeah, yeah. Okay. Don't get tangled. Okay. All right.
Hi, everybody. It's working. Good morning. I'm luckier than Dr. Freda. They got it working for me, so I get to have my slides, which makes me very happy. Just a brief sentence segueing from Dr. Freda's lecture to mine. I saw a 14-year-old boy years ago who wasn't growing well. And after today's lecture, you'll be able to tell why I was concerned about this boy. But it turns out that he wasn't growing well because he had a huge prolactinoma, which interfered with his pituitary secretions. And his tumor was so large that it was impinging on the optic chiasm. And this was, I think, about 2 decades ago, when the use of dopamine agonists was very new for the treatment. So we sent him to the neurosurgeons, and very gingerly and carefully, we decided to delay his brain surgery to remove this prolactinoma for a couple of weeks to see whether or not he would respond to these new treatments with dopamine agonists. And we put him on bergoline, 1 tiny pill every Saturday night. And this young man's giant macroadenoma of the pituitary, which was going to require maybe brain surgery, melted away into nothing. I'm talking to you about normal growth today, not abnormal growth, so unfortunately I don't have this particular child's story up and slides up. But he needed, in addition to cabergoline, a major hormonal intervention to help him grow and get through puberty. So, with that segue, I have no conflict of interest to declare. And by the end of this talk, I'm going to try to help you be able to tell whether or not this little boy, who is the same age as the nice girl he's dancing with, has a problem. I can tell you for sure that his parents are worried that he has a problem. They're afraid that he's going to grow up like this and be, a 32-year-old man who is severely dwarfed. But as you probably know, every single class in every single school in the country has a child who's the shortest in the class, and they all do not need major workups for 2 ethical reasons. 1, it's very expensive, and health dollars can be spent in better ways. And 2, it's very invasive to the child. And little kids don't like getting stuck, and little kids don't like any kind of medical intervention. So you have to have the usual cautions you have with doing unnecessary tests in mind, but with children they're compounded because little kids cry and scream and kick and really don't like to be bothered if they don't have to. So again, can you look into the seeds of time and say which brain will grow and which will not? I hope that with children and growth issues, the answer is yes. The teaching objectives of this particular class are to let you know how to determine whether or not a child's growth pattern is normal based on a really good history, really good physical examination, and maybe blood tests or an x-ray here and there. We're going to talk about the effect of puberty on growth, because that's the wild card, and the differential diagnosis and laboratory investigation of poor growth, indications for treatment of growth problems, which is a particular interest of mine because there is a whole new covert branch of pediatric endocrinology that I like to call cosmetic endocrinology, where parents want kids to be given growth hormones so that they'll be taller when the children are perfectly healthy. And then at the end, we're going to talk a little bit about prenatal growth problems. So the 3 big things to keep in mind when you're dealing with that one kid who's the shortest in the class is, when plotted, is he off the charts? Okay, is the absolute height or weight for that matter so extreme that he doesn't even plot on a normal growth curve? More important even than that is the rate of growth normal? And if you come away with one thing that you remember from this entire talk, I hope it will be that growth velocity matters. Abnormal growth velocity is pathology until proven otherwise in childhood. Okay, I am much more worried if I see a child whose height plots on the 50th percentile, if that child has always been plotting on the 95th, and then he comes in and is on the 50th. I am much, much more worried about that child than I am about a child who's been growing on the 3rd percentile, chugging along, staying on his centile every year. Growth velocity is critical in determining whether or not there is underlying pathology. And then, does it look like, based on bone maturation, that that child will reach a normal adult height? We really can tell that, and I'm going to show you in a couple of slides how we do that. Data that's suggestive of the need for further evaluation is if the absolute height of the child is below the bottom line on the growth chart. If the child is growing at less than 2 inches a year, I wrote from age 3 until the onset of puberty, because early in life, a lot of crossing centiles or growth depends on nutrition much, much more than hormonal and environmental issues. And in puberty, there's a wild card, because clearly if a child goes into puberty early, he or she is going to have a pubertal growth spurt earlier and will be crossing centiles. So puberty is absolutely necessary to take into consideration when dealing with growth. Crossing centiles downward, again, is abnormal. And if the predicted height, which is based on a bone age x-ray of the hand, and then again, we'll talk about how we do that, turns out to be much less than we would expect for the family. I'm going to talk again about target height in a little bit. I can't impress upon you enough the importance of a really, really good history. It will allow you to rule out certain pathologies and to be concerned about others, and obviate the need for unnecessary testing pretty frequently. A detailed history matters, and if you have the luxury of being in a consultation room and taking the time and not in the ER, with 10 charts on your door and worried about life and death, it really, really makes sense to give the time to get a good history, because it will impact on your impression and plan. What we're particularly interested in terms of the pregnancy and neonatal is maternal alcohol use, cigarette or drug abuse, intrauterine growth retardation, and any kind of neonatal trauma that might impact on postnatal growth. Nutritional status is critical. Chronic illness can present with growth issues, even if they're not hormonal chronic illnesses. So Crohn's disease, which is a GI disease, can present with growth failure prior to any GI symptoms. Psychosocial status is critical. There is an entity that used to be called, it's now politically incorrect to call it that, it used to be called the maternal deprivation syndrome. Now I guess you'd have to call it caregiver deprivation syndrome. But these are children who didn't get enough love, didn't get enough attention from one caregiver, and would not grow. And then when put in the hospital, taken out of this toxic home environment, they grew beautifully. So psychosocial status, chronic stress does impair growth. Growth records in terms of getting your history is critical, because you really want to know the growth velocity, and with 1 point on the curve, you can't determine that. Detailed past medical history and review of systems, and it's also very helpful to have the paternal heights and paternal height patterns. Physical exam, height, weight, and head circumference all should be measured carefully. And they can help you decide if a child is failing to thrive, what's probably the etiology, at least in terms of big categories. So if a child is relatively a good height, but the weight is terrible, it's more likely to be a GI issue. If the height is more deviant than the weight, it's more likely to be an endocrine issue. And if the head circumference is more deviant than both height and weight, it's more likely to be something genetic, neurological, and less likely to respond to interventional therapies. Upper and lower segment ratios and arm span are useful in determining dysmorphic features of patients, and we as endocrinologists certainly get all of those measurements on children with birth or poor growth or failure to thrive. In a detailed physical examination, clearly we're interested in vital signs. I mean, hypothyroidism can present with nothing less than bradycardia, sleeping bradycardia. You usually don't get the child sleeping, but hypertension and bradycardia are certainly signs that we would worry about. If there's a presence of a goiter, it's more likely to be hypothyroidism is the cause of poor growth. We look for neurologic signs, skin involvement for certain syndromes like neurofibromatosis and Kuhn-Albright syndrome. Dysmorphic features have to be looked for carefully because they can be subtle. You can have subtle genetic signs, and syndromes don't necessarily have to be full-blown syndromes. Many of these genetic syndromes have a spectrum of phenotypic manifestations, and it's very useful if you can diagnose, for instance, Turner syndrome mosaicism based on soft dysmorphic features. These syndromes are important to identify, not just to make you feel like a smart doctor, but Turner syndrome, for example, even though these children are not growth hormone deficient for the most part, will respond to growth hormone intervention and can impact on the quality of life of these girls later on. And it's an FDA-approved indication for the use of growth hormone, so it doesn't fall into the category that I like to call cosmetic endocrinology. And then we're clearly interested in the pubertal status of the patient because that makes a huge difference in how we interpret the growth curve. Endocrinologists or pediatric endocrinologists are very compulsive about measurements. So with little kids, we measure them lying down, we stretch them out because we base a lot of our intervention on whether or not the growth velocity is normal. And if we don't have accurate measurements, we can't rely on that. And in terms of children who can stand up, you just basically need a right angle on top of their head with the other part of the right angle flush against the wall. I have used Kleenex boxes as effectively as a $2,000 stadiometer, but what you really need is a good right angle. It's much better than those floppy things that maybe some of you remember from your pediatrician's offices because you're going to have a 1.5 centimeter difference with one of those floppy things. And if I'm worried about a kid who don't have a growth record, I will do a careful history physical and say, come back in 3 months so I can get a really good growth velocity. And if you can't rely on the measurement, that is not a useful bit of data. These are the CBC growth curves. I put them up just to let you know that the slope of the curve that's steepest is much later in boys than it is in girls. So if you can see, the slope of the curve that's steepest is in puberty here, maybe between 14 and 15 and a half, and in girls, much earlier, okay? So keep that in mind when you think of that slide with the girl dancing with the boy, okay? Now, puberty really does impact on when that peak growth spurt is. There are some limitations to the CBC growth curves, but having said that, I rely on growth curves tremendously in making many clinical decisions. Basically, they don't address children who are really deviant in height, either way too short or way too tall, and they're also based on cross-sectional data, which does not reflect the timing, variations in the timing of puberty. Upper to lower segment ratios, this just shows you how it changes with time, and this is a more graphic visual representation that I don't think you'll forget. On the cute factor, little kids are cuter probably because they have these huge heads in proportion to the rest of their bodies. Okay, arm span is normally about the same as the height. I like to think of it in terms of that Leonardo da Vinci drawing and the ability of girls or boys to do cartwheels, but arm span is usually about the same as the height. It is abnormal in some dysmorphic syndromes, so if you're trying to get another soft sign, this can be helpful. And I find it particularly useful in monitoring growth in kids who have spinal abnormalities, right? Because if they have spinal abnormalities, you're going to lose that height parameter, but you can monitor whether or not they're responding or growing properly by getting a good arm span. Sequence of normal pubertal changes in boys, again, look where that peak height spurt is. It's sort of between 14 and 15. The first sign of puberty in a boy is testicular growth. This is also important to remember because it's not something the boy's mother would know about. So when she's concerned that he's 14 and not yet in puberty, hopefully she hasn't looked for the first sign of puberty. In girls, look where that height spurt is, much, much younger. Earliest onset of puberty in girls that's considered not abnormally premature is, and Anybody shout it out? Don't be shy. Younger, younger. 8. 8. If you're 8 years old and you're starting puberty, it's on that bell-shaped curve. It's early, but it's not prematurely early. Okay? There are even some studies to suggest that it might be earlier than that, but we're not going to go there in this lecture. How about in boys? What's the earliest you can start having puberty and not have it be pathological, at least from the endocrine point of view? Younger. 9. Okay? So earliest for girls is 8, earliest for boys is 9. How about on the later end? Okay? How old can you be and have no signs of puberty and not have the doctors bother you and work you up for delays? No? What are we talking girls or boys? The girls first. 13. And boys, I'm talking about the first signs. I'm not talking about the first period. I'm talking about the first signs. In girls, the first sign of puberty is breast development. Usually, there are exceptions to everything, but usually it's breast development, the beginning of breast development. So if you're 13 years and 2 months old and have no signs of pubertal development and you're a girl and you find yourself in a doctor's office, you're going to have a workup for delayed puberty. And for boys, the age is 14. Okay? So early, normal, 8 to 13 in girls, 9, 14 in boys. These are bone ages. My favorite lab test. It's really, really easy to get and not a lot of radiation. It's just an x-ray of the hand. Okay? But if you look at the hand of a little kid, I don't know exactly how old that child is, maybe 4, and this person is probably about 18 or 19. You can see that there are no discernible epiphyses in the 4-year-old. In the, probably that looks like about a 9 or 10-year-old, you can see the epiphyses, right? I don't think I have a pointer here. Does this thing point? Yeah. Okay, you see the epiphyses? As the child gets older, first of all, they appear because they're not here. And I like to think of a little chubby 2-year-old who makes it best. I've got knuckles, they get dimples, right? Right? Next time you see a cute little kid, just look, there are no knuckles there, it's dimples. All right? Absent epiphyses. They appear, and by the time, and as the child gets older and matures, these fuse, and by the time the bone is mature, the growth plate is closed. And even if this person is given huge quantities of parenteral growth hormone, not capable of growing, okay? If that person makes a lot of growth hormone or gets a lot of growth hormone, they have clinical acromegaly, right? They might have distorted features or stuff, but they will not grow significantly in height. However, if your epiphyses are open and you have a growth hormone producing tumor that doesn't get diagnosed, well, you can become a giant, okay? And I remember seeing those in the Ringling Brothers barn in the Bailey Circus years and years ago when they still paraded people who had various illnesses and unfortunate circumstances. Okay, bone age and height predictions. There is a book called Grulich and Pyle, which is a Bible of pediatric endocrinologists. It was published a long, long time ago, but what it has is what a hand x-ray looks like for normal kids, from birth all the way through age 19. And you can compare the bone age you get on your patient with the hand x-ray in that book, and based on epiphyseal maturation, look at tables and and that child's height at that point in time, do a predicted height. These are extremely useful because they basically tell you, do you need to be worried about this child's final height? Or does it look like the way he's growing and the maturation of his bones and how tall he is at this point in time? Does it tell you that you can be reassured that it looks like he's going to reach an appropriate height? It may not apply to children with growth problems. If the bone age is significantly delayed or significantly advanced, these tables are not as reliable. And I always remind myself and parents that the bone ages reflect a moment in time and are helpful in current decision, but they're not prophecies. Okay, you can have a child who, if the bone age is delayed, okay, a child is 7 years old and his bone age looks like the norm of a 5-year-old. Is that good in terms of final height or bad? Just shout out an answer. Well, it means that you have more growing time, right? If your epiphyseal maturation is less, you with me? You basically can draw on that later on, right? Because it's going to take time for those epiphyses to mature. As long as the epiphyseal growth plate is open, you can keep growing. So if you're short, it's much better to have a delayed bone age than an advanced bone age. But having said that, this can change with time. If a child who has a delayed bone age goes through rapid puberty, the bone age can advance 3 years in one chronological year. And then all of this extra growth that you thought this child had in terms of potential evaporates. So it reflects a moment in time, it's useful, but it is not a prophecy your child will be 5'7". Target height is basically just how tall we think a child is going to be based on parental heights. Okay, again, it's just a frame of reference. It's not a prediction. Clearly, if your father is 6 feet and your mother is 5'6", it doesn't mean that you're going to reach an appropriate average based on the sex difference of the child and one of the parents. Okay, but it just does give you a frame of reference. If you have a child with 2 very tall parents and that child is, a little bit below the 3rd percentile, you'd be more inclined to evaluate that child than you would if the child's parents were also grown, on the 3rd percentile as adults. Constitutional delay is a variant of normal. And basically, it's just a late bloomer syndrome, more common in boys than in girls. Sometimes, for some reason, the body clock that determines the onset of puberty can be a little bit delayed. What's nice about constitutional delay, even though it can be quite difficult for the child, is that they do retain the growth potential because their bone age is delayed. And even though it looks like they're very short during childhood, they keep growing when their peers have stopped growing and usually do not end up quite short as an adult. Think back to high school. Usually it's more common in males than in females. Certain boys that were always relatively short compared to others, and then you see them 4 or 5 years after high school and they are no longer short. That's constitutional delay. It differs, the way we differentiate constitutional delay from genetic short stature is basically by the bone age, right? If you have constitutional delay, your bone age is going to be delayed, and you have that potential to catch up later on. If you have genetic short stature, your bone age is going to be equal to your chronological age, and when you hit 16, 17, growth is over. So that single x-ray is very, very useful in determining not only which children to be worried about, but also in following children year to year. Okay, so getting back to which kids do we worry about pathologic process going on if they're the shortest kid in the class, and which kid are we reassured that this is not, that there is no underlying pathology. If the history and physical exam are unremarkable, if the growth velocity is normal, that is critical. If the predicted height based on the bone age is in the normal range and in range for that child's target, and if the pubertal pattern is consistent with the parental pattern, usually no further workup is necessary, no intervention is necessary, and we reassure these families. So what do we worry about? Okay, these are the 3 big categories. If there are intrinsic defects of growing tissues, like the skeletal dysplasias, chondrodystrophies, different syndromes, there's an abnormal environment that's causing poor growth, like metabolic disorders, hypoxia, acidosis, renal insufficiency. And the last big category, which is my area of expertise, is endocrine pathology as a cause of poor growth. Here's an example of a child with abnormal body proportions. I don't think anybody would dismiss this as not pathological. The dysmorphic features are very obvious. This is a kind of short-limbed dwarfism with short arms, short legs, relatively large head circumference, and I don't think anybody would miss this diagnosis. But if you don't have dysmorphic features that are shouting out at you, you really have to look at a child who's not growing well or systemic disease. And before we start embarking on growth hormone stimulation tests, we rule out renal tubular acidosis and GI disease like Crohn's and inflammatory bowel disease and celiac disease, which is absolutely necessary to rule out. It's a lot more common than we used to think. And we get, basic general chemical lipid profile, urinalysis, CBC, signs of inflammation, and worry about systemic disease. If we have ruled out systemic disease with basic tests and ruled out dysmorphic syndromes, we then tend to search for endocrine pathology, and we narrow down the lab workup based on the physical examination. Clearly, if you have a child who's basically healthy and you get a history that's consistent with hypothyroidism, and on physical exam there's a huge goiter, and you do a blood test as part of your screening for thyroid and it comes back low, again, that child doesn't need a growth hormone test. You know that she's not growing or he's not growing because they're hypothyroid. So thyroid profile is part of screening. Prolactin for sure, like that child that I mentioned at the very beginning of this talk, the 14-year-old boy who had a macroadenoma of the pituitary that was hypersecreting prolactin. Cortisol is the one hormone that, if present in excess, will interfere with growth, as opposed to if it's absent. Okay? A growing child is exquisitely sensitive to glucocorticoid, and if you overtreat a child with Addison's or congenital adrenal hyperplasia even slightly, they will not grow. And that's one of the challenges of treating children with Addison's disorder. You want to make sure you're giving them enough so that they don't have glucocorticoid deficiency. On the other hand, if you give them even a tad too much, they will not grow. And androgens are usually part of the evaluation. Hypersecretion of androgens might be caused by, this is not a talk on pathology. I'm supposed to be telling you about normal growth, so I'm not going to go there in detail, but just know that these are all of the hormonal evaluations that we do consider when we're worried about endocrine pathology in children. I think I'm going to focus. Okay, so thyroid hormone and growth, it's a major contributor to postnatal growth. It's important for skeletal maturation, direct effects on epiphyseal cartilage growth and differentiation, and it also has a permissive effect on growth hormone secretion. So if you have a child who's hypothyroid and you run and do a growth hormone stim test on this child to see whether they're secreting growth hormone and it comes back low, it's a totally invalid test because the patient was hypothyroid at the time. And hypothyroidism will interfere with growth hormone secretion. Glucocorticoids inhibit DNA synthesis, they chronically inhibit GH release, and they also antagonize growth hormone action. This becomes problematic because we use glucocorticoids for treatment of many inflammatory diseases. Our colleagues in pediatric cardiology, pediatric allergy, pediatric renal, pediatric joint diseases, they all use glucocorticoids pretty frequently, and a lot of these patients have severe growth impairment as a result of getting high-dose glucocorticoids that they need for treatment of their underlying disease. Sometimes giving them excess growth hormone will combat this to some extent, but clearly these children have acute medical problems that are more severe and need attention, that are more critical than how tall they're going to be as a grown-up. This is an interesting point to remember. As you probably know, there is an obesity epidemic in this country, and we get a lot of referrals of really obese children from pediatricians who are telling us, please rule out Cushing's. Right? Cushing's disease is characterized by massive obesity. I can rule out Cushing's in a child much more easily than Pam Freda can rule it out in an adult, because I have a growth curve, and her patients are no longer growing. I just mentioned to you that if you have too much glucocorticoid on board and you're a kid, you don't grow. So if you are really, really obese and you're growing beautifully, you don't have Cushing, okay? Hypernutrition makes you grow taller as a child. It also advances your bone age, so you don't necessarily end up taller as an adult. But you can rule out Cushing's pretty much, and again, I can't say this often enough, there are exceptions to every rule, but pretty much you can rule out Cushing's with a growth curve, okay? If a child is growing normally, it's very unlikely that they have too much glucocorticoid on board. And this growth curve sort of proves it. Obese children tend to be taller, growth velocity is normal, bone age is moderately advanced, final height is in range for target, and puberty tends to occur earlier in obesity. Okay, finally we get to talk a little bit about growth hormone. This is just to remind you that growth hormone is made in a very, very, very central part of the brain. Okay? I think my pointer stopped working, but the pituitary gland is in a critically important part of the brain, very near the optic chiasm. Any tumors in that area can cause a lot of problems, even if they are not malignant. It's like New York real estate, location, 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 right? You have a big tumor in that location, you can go blind, and the morbidity is terrifically bad because of the location of the tumor. And very often kids with tumors of the pituitary that because of space-occupying lesions there, they're not producing growth hormone. They may present with impaired vision, with tunnel vision, or growth failure. Okay, the causes of growth hormone deficiency can be anatomic. Okay, so they can be congenital malformations. Any midline defect of the brain, again considering the anatomy, can result in growth hormone undersecretion. Absence of the corpus callosum, absence of the septum pellucidum, any midline holoprosencephaly. A lot of these kids with midline congenital malformations of the brain will have growth hormone deficiency. Acquired brain tumors, post-trauma or inflammation, post-irradiation. There are genetic forms of hypopituitarism. And psychosocial dwarfism, which I mentioned earlier, also can cause growth hormone deficiency. There are neurosecretory deficiencies of growth hormone, not really well understood, where if you give pharmacologic stimuli, the child will pass a growth hormone stimulation test, but for some reason, on their own, they don't have the same frequency or amplitude of growth hormone pulses that normal children have. There's bioinactive growth hormone, and then there is idiopathic isolated growth hormone deficiency. Growth hormone has many sites of action, muscle, adipose tissue, linear growth, and on bone metabolism. You can look at this slide and read all of the bullets. I'm going to move forward on how we assess growth hormone secretion. The half-life of growth hormone is very, very short. So if you want to determine whether a child is deficient in growth hormone, you can't just get a random sample of blood and send it off to the lab, because it might have been, the growth hormone level might have been extremely high 15 minutes before and you missed a peak. So in order to determine whether or not an individual child can make enough growth hormone, we test them by using provocative stimuli and sequentially checking blood every half hour to see whether or not they can have a peak that in 2015 is determined by a growth hormone level greater than 10 nanograms per ml. Just so you know how confusing it is to make this diagnosis of growth hormone deficiency, in my lifetime, the peak used to be 5, and then it was 7, and now it's 10. And this change occurred with the with the genetically engineered growth hormone. So basically, the more growth hormone was available, the more lenient we are in saying which children are considered deficient. It's totally arbitrary. At the beginning of my career, growth hormone was obtained from culled pituitary glands, and it was very, very hard to obtain. And then in 1985, Genentech made genetically engineered growth hormone, and that's when everything changed, and we were much, much more willing to call kids deficient. It also opened a Pandora's box of people who want to treat children who are not deficient just to make them fall. Okay? As you know, if the epiphyses are open and you give growth hormone, a child will grow. Follow. We also can check physiologic stimuli. Sleep, definitely. There is more growth hormone secreted during sleep than during waking hours. Powerful exercise results in growth hormone pulses, and hypoglycemia can also do this. I like to inform parents of this physiologic information because it sounds like grandma's advice. You know, if your child gets a good night's sleep and gets fresh air and exercise and doesn't eat too much candy, they will grow better. Here is a slide that shows growth hormone secretion in a 12-year-old male who is prepubertal. Nice peak early in sleep, like in the beginning of sleep. But look what happens in puberty. Okay? The frequency and amplitude of growth hormone peaks dramatically increases. There is synergy also between growth hormone and sex steroids, so that explains the really impressive pubertal growth spurts that we see clinically. We talked about interpretation of the growth hormone stimulation test. So today, greater than 10 nanogram mLs is considered growth hormone deficiency. Between 5 and 10, probably deficient. I'm most comfortable in the less than 5 and the greater than 10. That gray area, these are not really reproducible tests. I'm telling you this as someone who ran the pediatric endocrine testing unit for 15 years. If you do the same growth hormone stim test on the same child a week later, you know, you might get a peak of 8 instead of a peak of 11. So I think I used to believe that we should have the equivalent of like Jones criteria for making a diagnosis of growth hormone deficiency, where in addition to an abnormal GH stim test, you also need to have a child with an abnormal growth velocity, a child with a delayed bone age, a child whose predicted height is less than target, so that you're taking more than one factor into consideration, basically to determine whether or not A, a child should be treated, and B, whether or not it's likely that that child will respond to treatment. But using a growth hormone stim test alone to make this diagnosis, in my opinion, is insufficient. There are many things that will cause an abnormal peak growth hormone, like obesity, diabetes, psychiatric disease, blindness, sex hormone deficiency, IGF-1 deficiency, GH receptor defects, treatment with glucocorticoids. So even if you have the results of this test, you really need to be careful in the interpretation. These are the currently FDA-approved indications for treatment with growth hormone. Peak growth hormone less than 10. They like to hold on to that number. Turner syndrome and mosaicism, chronic renal insufficiency, Prader-Willi, intrauterine growth retardation with lack of catch-up. We'll talk about that in a few minutes. Severe idiopathic short stature with poor predicted heights in girls and boys. That is a can of worms. That is a mess in terms of reimbursement, in terms of whether or not it's really necessary. It's in terms of the genetic environment that the child comes from, in terms of the part of the world that the child comes from. That's a category that I personally hate. Adult growth hormone deficiency. To be considered deficient as an adult, you need a peak growth hormone, I think less than 3 nanograms per ml, whereas in childhood it's 10. And I think it's 3, it might be 5. But it's definitely at least half of what it is for children. And the treatment dose of growth hormone in adults, if you have a child who has like no pituitary gland and you've been replacing them, you know they're definitely deficient. Once they're finished with puberty, and they still need growth hormone for optimal bone health and for quality of life issues, the dose of growth hormone that adults need is 1/10 of the dose that children need by weight. Okay, so that's grown-ups need some growth hormone, but much less than kids do. And it's also used in AIDS wasting and short gut syndrome. And when you make a diagnosis in a growth hormone deficient child, there is nothing more satisfying as this growth curve proves. They grow like Jack and the Beanstalk. They have wonderful catch-up growth. It's a fantastic treatment. Here's a plug for endocrine in general, at least pediatric endocrine. You can really fix things, you know, as opposed to a lot of other specialties where you can't. No, a child born with congenital hypothyroidism, and you give them thyroid hormone replacement, and they can grow up to be valedictorian of their medical school class. And without treatment, they are what you used to call cretins, disabled for life, institutionalized for life. So intervention and cures are really possible, and it's exquisitely satisfying. Adverse reactions associated with growth hormone therapy, short-term concerns, these are all really rare. Basically, because if you're treating a child with a hormonal deficiency, you are replacing something that should be in the body, and you're replacing it at the same dose that the body would be making it, so it doesn't have the same kind of adverse reactions as using other drugs and chemicals that don't naturally belong in the body. If I'm giving a child growth hormone, I'm replacing his endogenous growth hormone. But there are some adverse reactions that infrequently occur, and they include slip capital femoral epiphysis, more common in overweight teenage boys, scoliosis, intracranial hypertension, edema, lymphedema, more common in the kids with Turner syndrome, and gynecomastia, which is rare. Long-term concerns, and there are long-term follow-up data on kids who have been treated with growth hormone. I think it started to be used in the 1950s, and it's got a really good long-term track record. But there remains a question of possible increased risk of specific malignancy recurrences when growth hormone is used in children who have had previous cancers, and a question of increased risk of Hodgkin's disease and colorectal cancer. One thing is clear, we monitor dosing very, very carefully and give growth hormone by monitoring IGF-1 levels. IGF-1 is, I'm going to talk about it, I think, next. Here we go. It's located on the long arm of chromosome 15. Gene expression is tissue-specific. Growth hormone is the primary regulator of IGF-1 gene transcription, and it's necessary for postnatal non-intrauterine growth. So we can measure IGF-1 levels in the blood, and IGF-1 has quite a long half-life. So for all children getting growth hormone, we monitor their IGF-1 levels and make sure that they don't exceed the norm for age. So in terms of long-term malignancy risk and those concerns, if we keep the child's IGF-1 in the mid or high normal range for age, it's less likely that we are inadvertently causing potential long-term harm because we are replacing growth hormone and not overdosing children. So IGF-1 is synthesized in the liver in response to growth hormone. Primary IGF-1 deficiency has been described. It's called Laurent syndrome or GH insensitivity resistance. And this is a family who has IGF-1 deficiency. Their growth hormone levels when measured are quite high, but their IGF-1 levels are very, very low. Clearly, they will not respond to exogenous growth hormone, right? That's what this young man has. He's 32, and that's his 19-year-old bride, who is, I think, the mayor of a town in Ecuador. That's what the parents of the shortest kid in the class are worried about their kid has. We can treat with IGF-1, okay? So it also can and has been used rarely to treat growth hormone deficiency. There are studies that use combined growth hormone plus IGF-1 that show better growth than with growth hormone used alone, but this is really in the realm of research because there is a problem with IGF-1 treatment, and that is a side effect of hypoglycemia. It is, IGF-1 is insulin-like growth factor, and the hypoglycemia is something you really want to avoid in pediatrics, particularly because low blood sugars will interfere with brain development and have long-term neurologic consequences. slides on intrauterine growth. How do you define a small newborn? Small for gestational age is a newborn whose birth weight or birth length is at least 2 standard deviations below the mean for the infant's gestational age. And there are 3 big causes of prenatal growth failure. 1 are syndromes, skeletal dysplasias, 2 environmental factors, and 3 hormonal factors. Now, it's interesting that only 10% of patients with SGA have placental or fetal causes. And if you look at the next slide, 90% of children born with SGA will catch up. So what this means is, if there's some environmental toxin or something placental, or some maternal factor like alcohol or cigarettes or drug use or something, once the child is taken out of that toxic environment, they catch up on their own. Okay, approximately 90% of children born SGA will experience catch-up growth by age 2. These are the fetal factors that don't catch up. So if there's something genetic or some viral infection that affects the fetus or congenital malformations, those usually, after age 2, don't get any better. Those children persist in being small. Comment about IGF-2. It's a gene located on the short arm of chromosome 11, and it is the main intrauterine growth factor. Okay, so excess levels of IGF-2 in intrauterine life are associated with overgrowth syndromes, and insufficient IGF-2 in intrauterine life is associated with intrauterine growth retardation. There are long-term consequences of babies small for gestational age. A prolonged intrauterine nutrient deficiency may have postnatal consequences, like a slow growth rate, some degree of resistance to growth hormone, IGF-1, insulin, elevated androgens, there's an increased risk of obesity, premature adrenarche, type 2 diabetes, metabolic syndrome, and cardiovascular disease. So we tend to monitor these kids who were born small for gestational age who didn't catch up, and we are on the heightened lookout for these particular diseases. So let's get back to this boy and girl. I will tell you that he's perfectly normal, okay? He was a boy whose puberty started late. When's late? 14, right. And she was a girl whose puberty started early. When's that? 8, okay? And here they're both, I don't know, maybe 11 years old. So that explains the picture. I'm ending with a slide from a medical ethics talk that I give. It's a real patient, an 11-year-old boy with short stature, normal growth velocity, normal history, normal physical, normal labs. Peak growth hormone post-stimulation is 10.4, normal, right? Predicted height 5'4", in the normal range, but parents not happy with it. And it was also in range for his family, so in range for target. Both he and his parents want you to treat him with growth hormone or any other hormonal therapies that might help him get taller. And they're able and willing to pay for it all out of pocket, and they're even interested in bribing. So, two questions come up here. One, can I make this boy taller? Do I have enough tools in my doctor bag to actually make him taller? And the second question is, should I make him taller? I'm going to answer the first question and let you think about the second yourself. I can make him taller with his epiphyses open. I can give him growth hormone, right? He will grow if I give him growth hormone. I could give him IGF-1. Androgens have also been used in certain situations. Low-dose estrogen is a tool that's used, again, in certain situations, not for this particular child. GnRH agonists are used to turn off puberty. So I could buy time to make him taller to slow down his epiphyseal maturation if I give him GnRH agonists and growth hormone simultaneously. And we're coming full circle back to that patient I had with a prolactinoma who had his tumor shrink with cabergoline, But we also had to, when his tumor shrank, we also started making gonadotropins and making testosterone, which was advancing his bone age. So we had to turn off his puberty dip and growth hormone while he was getting the cabergoline, and it all worked out very nice. But I did have the tools in my doctor bag to manipulate his growth to his benefit. You can also use those tools to manipulate growth to the benefit of someone who's not sick, if you think it's a benefit. And lastly, and I don't have time for this, I wish I did, but aromatase inhibitors. Estrogen is necessary for epiphyseal maturation. If you don't aromatize testosterone to estrogen, you will not fuse your epiphyseal. This is a treatment that is being investigated as a potential adjunct to giving growth hormone, clearly only in boys, because you don't want girls not to be able to make estrogen and to make tons of testosterone. But this was discovered by my mentor, Dr. Akira Morishima, one Tuesday afternoon when I was a fellow here in clinic. I was following a girl who I thought had polycystic ovary syndrome, slightly hirsute, slightly virilized, and she was brought into clinic that Tuesday afternoon by her brother instead of her parents, and her brother was about 6'9", and we don't see that in endocrine clinics. So Dr. Morishima got really excited, like, you know, what's going on here? Really, really tall brother and this virilized girl, and he took me into a room. I have a strong visual memory of it, and he said they both have the same enzyme defect. And I'm thinking, oh man, I have so much to learn. And he postulated that they both had aromatase deficiency. Her aromatase deficiency was expressed as insufficient estrogen, too much testosterone for her estrogen level. His aromatase deficiency was expressed as, you know, if he made a little extra testosterone, it was a spit in the ocean. It wasn't clinically noted, right? But he never fused his epiphyses. And Dr. Morishima sent Big Brother, who was 23 at the time, to the X-ray department on the 3rd floor of Baby's Hospital, and got an X-ray of his hand, and lo and behold, his epiphyses were open. And he collaborated with people in the lab and proved this, and that was what's called a prismatic case, because then it became known that you could use aromatase inhibitors to prevent epiphyseal maturation and use this to help kids get taller. So very exciting that in my lifetime I got to see that go from the clinic to the lab back to the clinic, because there are research projects going on using aromatase inhibitors in conjunction with growth hormone in boys to prolong growing time. Having said all that, yes, we have the tools, yes, we can manipulate growth. These are 3 very important words that you should remember, not just as medical students, but throughout your lives as doctors. Above all, do not harm. And if you're going to use anything experimental, especially for cosmetic purposes, as pediatricians, you have to be worried about decades and decades into the future, as opposed to geriatricians who don't have to worry about it a person's whole life. So anyways, good luck to all of you.
It's not really know what happened if I took growth hormone for the rest. It's not really know what would happen.